Alex did not feel sick. He was 29, went to work, went to the gym, complained about laundry, and assumed cancer was something that announced itself with dramatic pain and a hospital scene. Then one morning in the shower, his left testicle felt different. Not agonizing. Not even clearly wrong. Just firmer, with a small lump that he could not remember being there before. He checked again the next day. Still there. Then he did what many people do when the symptom is awkward and the worst possibility is frightening. He tried to negotiate with it. Maybe he had bumped himself. Maybe it was an infection. Maybe bodies were simply lumpy. He searched online, became terrified, closed the browser, and waited. This is a composite story, built from the typical medical path described by major cancer organizations. Alex is fictional, but the choices, tests, treatments, and consequences are real. Testicular cancer is uncommon, but it matters partly because of whom it tends to affect. It is most often diagnosed in teens and younger or middle-aged adults. The average age at diagnosis in the United States is about 33. That means it can arrive while someone is building a career, dating, starting a family, or assuming serious illness belongs to a much later chapter. And it may not hurt. The most common early clue is a lump, swelling, or enlargement of a testicle. Some people notice heaviness in the scrotum, a dull ache in the lower abdomen or groin, discomfort, or sudden swelling. Rarely, hormone-producing tumors can cause breast tenderness or growth. If disease has spread, symptoms can include back pain, coughing, chest pain, or shortness of breath. But symptoms do not prove cancer. Infection, inflammation, cysts, and other non-cancerous conditions can look or feel similar. That uncertainty is exactly why a persistent change deserves a medical examination rather than a private verdict. Alex finally booked an appointment after 2 weeks. The delay felt enormous to him. His doctor did not shame him and did not diagnose cancer by touch. She examined him and ordered an ultrasound. An ultrasound uses sound waves to create images of the testicle. It can help show whether a lump is inside the testicle or outside it, and whether it looks solid or fluid-filled. A solid mass inside a testicle raises more concern. The scan was painless, but the room was quiet enough for Alex to hear every anxious thought in his head. The results showed an intratesticular mass suspicious for cancer. Next came blood tests for tumor markers. These may include alpha-fetoprotein, beta-human chorionic gonadotropin, and lactate dehydrogenase. Some testicular cancers raise one or more markers, others do not. A normal result cannot automatically erase a suspicious mass. The numbers help doctors understand the tumor, establish a baseline, and later watch how it responds. Alex expected a needle biopsy because that is how many cancers are diagnosed. Testicular cancer usually takes a different path. When the findings strongly suggest cancer, the standard operation is a radical inguinal orchiectomy, removal of the affected testicle and spermatic cord through an incision in the groin. Doctors generally avoid cutting through the scrotum to sample the mass because that could alter lymphatic drainage and potentially spread tumor cells locally. The surgery is both treatment and diagnosis. Only after a pathologist examines the removed tissue can the team know exactly what it is. Before surgery, Alex faced a consequence he had never attached to the word cancer: fertility. Testicular cancer itself can affect sperm quality, and chemotherapy, radiation, or some surgeries can reduce fertility temporarily or permanently. Many survivors later father children, and one healthy remaining testicle is often enough for sperm and testosterone production. But often is not the same as guaranteed. Sperm banking before treatment can preserve an option, especially if more therapy may be needed. The conversation felt brutally premature. Alex was not trying to have a child. He was not even sure he wanted one. Now he had to make a future-facing decision while still absorbing the possibility that part of his body would be removed. He banked sperm. Then the testicle was removed. Physically, recovery from an uncomplicated orchiectomy may be much shorter than the emotional adjustment. Alex went home with pain instructions, activity limits, and a body that looked different. He had been told that the remaining testicle would usually make enough testosterone. He had also been offered a testicular prosthesis, an implant placed for appearance rather than function. He declined at first, then wondered whether he had chosen too quickly. There is no universally correct response. Some people barely think about the change. Others grieve it, worry about intimacy, or feel that masculinity has been damaged even when sexual function remains normal. Those reactions are not vanity. Cancer can turn anatomy into identity overnight. Pathology showed a germ cell tumor. More than 90% of testicular cancers begin in germ cells, the cells involved in making sperm. Doctors broadly divide these cancers into seminomas and non-seminomas because they can grow differently and may require different treatment strategies. Mixed tumors are generally treated as non-seminomas. But the tumor type was only part of the answer. Alex still needed staging. His team repeated tumor markers and ordered imaging, commonly including scans of the abdomen and pelvis and, depending on the situation, the chest. Testicular cancer often follows lymphatic pathways to lymph nodes deep in the abdomen. Staging asks whether disease appears limited to the testicle, involves nearby lymph nodes, or has reached distant organs. Alex had stage 1 disease. The scans showed no spread, and his markers returned to normal after surgery. That was excellent news. It was not the same thing as returning to the morning before the lump. Depending on the exact pathology and risk features, stage 1 patients may be offered active surveillance, a limited course of chemotherapy, radiation for selected seminomas, or surgery involving abdominal lymph nodes in selected cases. The best choice depends on tumor type, recurrence risk, side effects, medical history, and whether a person can reliably complete follow-up. Alex chose surveillance. Surveillance does not mean doing nothing. It means using scheduled examinations, tumor marker blood tests, and imaging to look for recurrence, especially during the early years when the risk is greatest. It can spare someone treatment they may never need. It also asks them to live beside uncertainty. For Alex, every appointment divided time into 2 eras, before the result and after it. A routine blood draw became a referendum on his future. A sore back could become metastatic cancer in his imagination before lunch. Friends heard no chemotherapy and assumed the story had ended. Alex heard come back in 3 months. This is one of the strange consequences of a highly curable cancer. Testicular cancer has an excellent outlook, and most cases can be cured even when diagnosed after spread. In localized disease, survival is exceptionally high. Those facts are genuinely hopeful. They do not make surgery, chemotherapy, skin anxiety, fertility fears, or the possibility of recurrence imaginary. For people who need chemotherapy, cure may come with nausea, fatigue, hair loss, infection risk, and possible effects on hearing, nerves, lungs, kidneys, cardiovascular health, or fertility, depending on the drugs and doses used. Radiation can carry its own short and long-term risks and is now used more selectively. Surgery to remove abdominal lymph nodes can sometimes affect ejaculation, though nerve-sparing techniques may reduce that risk. Treatment is individualized because both the cancer and the cost of curing it matter. Survivorship also continues after the last scan. Follow-up may include attention to testosterone symptoms, heart and metabolic health, fertility, sexual health, emotional distress, and the small risk of cancer developing in the other testicle. Some survivors need support for anxiety or body image concerns. Asking for that help is not an overreaction. It is part of treatment. Alex eventually stopped checking his body 10 times a day. He learned what was normal for him without turning every sensation into an emergency. He kept his appointments. He told a new partner what had happened and discovered that the conversation was less catastrophic than the one he had rehearsed alone. Most importantly, he stopped treating embarrassment as medical evidence. A painless lump is easy to postpone because pain feels like the body's alarm system. But cancer does not promise to hurt. And while routine population screening for testicular cancer is not recommended, awareness still matters. You do not need to diagnose yourself or perform a perfect ritual. You need to know your usual anatomy well enough to notice a meaningful change and get it checked. If you find a new lump, swelling, firmness, heaviness, or persistent pain, contact a qualified health professional. Sudden severe testicular pain is also urgent because conditions such as testicular torsion can threaten the testicle within hours. The point is not to panic. The point is not to wait for certainty before seeking care. Alex's lump did have consequences: surgery, fertility decisions, altered body image, years of follow-up, and a new relationship with uncertainty. It also led him to a cancer that was still highly treatable. The most dangerous part of his story was not that he failed to recognize cancer on sight. No one should be expected to do that. It was the belief that being young, feeling healthy, and having no pain made the change safe to ignore. So, if your body quietly tells you that something has changed, how long will you make it shout before you listen?